will improve as a result of that. And I think we're also in a position where we're in this gray zone of trying to figure out how to get to the next level while assessing patient satisfaction. And I would ask you not to settle for what we have now. I don't think that's what we're really after, to your point. But through perhaps community assessment processes where people are engaged in giving their feedback, let's find out what really matters. That's the way I would go about it. Yes.
Hi, how are you? My question is, as I look at what we do here in the healthcare community, as providers, we typically see our patients probably 20-minute appointments, 30-minute appointments for about 5 or 6 times a year, which is about 100 minutes a year we get to impact, truly face-to-face impact their lives. The rest of it is white space that they live in. And that means all of the things that you have talked about from the socioeconomic and the disparity point of view, where does health literacy for that patient, and I looked at almost every slide, where is that embedded in your program to help the patient be a partner in their health care, but to educate them so they know the right things to ask and the right things to do?
Yeah, great question. We've really struggled with the health literacy piece because it's huge. I would say that there's actually even a more foundational issue, and that's literacy. We have a huge issue around just general education and literacy, and we have disparities there. So we're asking much of our population to be health literate when they're not even literate. And it's interesting because if you have an education, if you have an advanced education, you still may not be health literate because we've created such a complex system and processes. So we agree with you that it's critical, but I think it requires even more foundational effort. And this is a great place for when you're looking at community systems, is to begin to assess what are the literacy rates and then what are the health literacy rates. I don't think you should deal with them separately. I think they go hand in hand. And I think it just gets to the point that if we stop and revisit and we create systems around people, then we put in place what's needed for the people at the time. And that's why, to me, the community health assessment is so critical. We should have that everywhere around Virginia so we know what's needed, we know what's available in the community, we mobilize those resources. I'm a big believer that we have many hidden assets in every community, and if we just elevate to awareness what's going on, those assets come out. I see that in emergencies, so I know that it works. People always come out to help in an emergency because they see a need. Well, let's make the need more visible, and I think then we'll get to some of these other really difficult issues like health literacy. I think we're done. Thank you very much, and have a great meeting.
Thank you so much. Thank you. All right. Thank you so much, Dr. Levine. You know, I think we all know that there are disparities around the state, but we're so excited about the level and the amount and the depth of the information that is coming out through this Wellbeing and Virginians plan. It's so exciting because now we have the tools that we need, and as you're going to see later today, how wonderfully this dovetails in a holistic approach to ensuring well-being for Virginians, how well it dovetails with the Culture of Health national campaign that we're also launching or activating within Virginia. So thank you very much. We're going to take a 10-minute break. Of course, I forgot to bring my phone, so I'm going to have to depend on you to come back in 10 minutes. I did want to let you know that all of the PowerPoints will be available to you following today's event. And I also, just a quick note to our poster presenter, judges. We appreciate your help with judging our poster presentations. If you could be sure to have your judging sheets to our registration desk by 1:30, that'd be great. See you back in 10 minutes. We have 2 additional posters I just wanted to share with you, so make sure you haven't taken an opportunity to look at them. One is from Wayne Campbell, Implementing Lean Healthcare in the Acute Rehab Setting. It's poster number 38. And poster number 37 is from Dr. Pam Hash and Melissa Gomes, and it's Connecting Professional Practice and Technology at the Bedside. Also, for those of you doing our exhibitor bingo, I wanted to let you know that neither Carillion nor Shenandoah were able to make it here because of weather concerns today. So you do not have to, oh, and I think also Centra. So don't worry about those 3, Carillion, Shenandoah, and Centra, because you'll be looking all day. Oh, and one other thing. I know a number of people have had questions, gone up to the front desk and asked about how are they going to get their CE for this. So I think we mentioned it at the outset, but I want to just reiterate it for you. We will be getting you a survey via email within the next several days before the end of the week. And click on the link in the email, complete the survey, and that's how you get your certificate. All right? Kevin?
Good morning. My name is Kevin Shimp, and I'm the Government Relations Board Member for VNA. I'd like to thank you all for coming out today and getting out here in this weather. I'm glad to see that it warmed up last night and it wasn't so bad this morning. It's my pleasure to welcome our next speaker, Andrew Lamar. Andrew has served as the principal of Lamar Consulting since forming the company in late 2012 and brings more than 10 years of political and legislative experience to his new role as VNA's lobbyist. He previously served as policy advisor and deputy director of legislative affairs to Virginia Governor Bob McDonnell. In that role, he helped develop legislative strategy and oversaw coordination between the governor's office, the cabinet, and the General Assembly. Andrew's extensive background in Virginia state government and politics also includes working for the Speaker of the Virginia House of Delegates, Bill Howell. Please welcome Andrew as he joins us to provide you with a legislative advocacy primer and an update on legislative issues. Andrew.
Good morning. How's everyone? Appreciate you all having me for a few minutes to get out of the General Assembly building. It's kind of a nice break. Friendlier faces, politicians, and I have spent the last 34 days together, and it's good to be here. If you haven't been outside, it has stopped raining, so there's that to look forward to. And I think the sun might come out eventually. Want to give you a little bit of an overview. Some of you may be well familiar with the legislative process, but I would give you a little bit of background on that. Kind of talk a little bit about how things work down at the Capitol with the General Assembly and the governor and his administration, and talk to you a little bit about some of the big issues that have been specifically facing nurses during this legislative session. Talk a little bit about some of the things that I think are on the horizon, and I think due to a slight change of plans, I'll have the opportunity to introduce to you the First Lady of Virginia, Ms. Dorothy Mcauliffe. So just a little bit, I still am from North Carolina. I don't know why that's scratched out there. But I figured this is my first opportunity, my first session working with the Nurses Association, so I thought I'd tell you a little bit about myself. I am from North Carolina, I promise. I've been in Richmond since 2007. Graduated from the University of Mary Washington, which is what originally brought me from North Carolina to Virginia, and spent some time in Fredericksburg. That's how I wound up working with the Speaker, who's from there. Did the Sorensen Institute for Public Policy at the University of Virginia. I'm probably, you all are much more normal people than I am. I'm kind of a political nerd. I'm into that kind of stuff. If any of you all are interested in politics, interested in policy, I would encourage you to check out the Sorensen Institute. It's a very good program that brings together people from all across the state, people from urban areas, rural areas, Democrats, Republicans, independents, libertarians, whatever. And it really emphasizes, here's all of our various backgrounds. We all come from different perspectives, but at the end of the day, when we come to Richmond, how can we better figure out how to work together to get things done, to improve public policy here in state government. So just a little side note, I wanted to point that out for you. Maybe someday we can take some of those lessons to Washington. But I think we do a pretty good job in Richmond in terms of being able to work together on big issues. She mentioned, Kevin mentioned that I was the Deputy Director of Legislative Affairs for the governor. Essentially, I was the governor's lobbyist. He would say, these are the things that we want to work on, and just as you all tell me, here are the priorities that we have. I take those priorities and take those issues and work together with stakeholders, with policymakers, with legislators, and figure out what do we need to do, come up with the strategy, and take it down to the Capitol and find a way to get it done. I just, for what it's worth, come from a family of healthcare professionals. My mother's a nursing home administrator. I have a sister who's a registered nurse. My stepmother is a nurse practitioner. An aunt who's a registered nurse, and like many of you, I'm sure, are all from healthcare families. But I think it's a cool opportunity for me as an individual to be able to represent the profession that my sister works in, and I appreciate the opportunity to work with you all. Just a little bit about what's going on in the session right now. This is the 34th day of a 60-day legislative session. Here in Virginia, we meet every year. The General Assembly convenes the second Wednesday in January every year, and on even-numbered years, they meet for 60 days. And in odd-numbered years, they meet for 45 days. They consider that 15 extra days is plenty of time to figure out how to spend $100 billion of your money. So that's the only extra time that they need. So this being an even-numbered year, they convened on January 13th, and if all goes as planned, and we'll see, sometimes it does, sometimes it doesn't, the General Assembly will adjourn March 12th, sine die, sine die. They'll adjourn without any plans to come back for the year. Today's a crossover day, so if you made it down to the General Assembly this morning, there was a few legislative meetings going on this morning, but for the most part, all of the activity right now is happening on the floor of the House and on the floor of the Senate. Crossover day is the unofficial midway point in the General Assembly session. It is that time by which, according to the rules, all of the House bills have to complete their action in the House of Delegates and move over to the Senate and vice versa. If you have a House bill that doesn't make it to the Senate by midnight tonight, I don't care if it was voted on or not voted on or whatever, if it doesn't transfer over, then it's dead for the year. So fortunately, some of the bills that we've been working on and paying attention to have made it beyond that point already. So I told you this is the 34th day, so it's actually a little past midway. But technically, today's crossover. Each chamber will, after today, button up some of their work on their respective versions of the state budget. As I mentioned, it is a budget year. So on next Sunday afternoon, when you all are at home watching the Daytona 500, I'm sure, the General Assembly will be down in the House and Senate committees debating the finer points of their prepared budgets, and they'll advance those to the full chambers, and they'll approve their budget February 25th. A little bit about the General Assembly. It's the oldest continuous lawmaking body in the New World. All the legislators love to talk about that. It's a pretty cool thing for them to be a part of, and I think it's worked pretty well. The House of Delegates is made up of 100 members. They're elected every 2 years, in odd-numbered years. It's always been the tradition. There's 66 Republicans right now, 34 Democrats. In the state Senate, there are 40 members. As the chamber has gone back and forth quite a bit recently. There's currently 21 Republicans and 19 Democrats. The House of Delegates is presided over by the Speaker. He is a member of the body. In other words, he is a delegate himself. Bill Howell is from Fredericksburg and Stafford County. It's interesting, so the state Senate is presided over by the Lieutenant Governor, who's at the federal level, the Vice President, Lieutenant Governor's roles are fairly limited, but they do preside over the chamber. They vote in certain instances to break ties. I was at a breakfast with the Lieutenant Governor, Ralph Northam, last week, and it was kind of funny. He said there were many times in the whenever he was previously in the state Senate, he voted on a lot of things, and he won some votes and he lost some, but he said it's kind of nice being Lieutenant Governor because every time I vote, I get it right as the tie-breaking member. The Speaker in the House is a very powerful position. I think it's probably the second most powerful position to the governor in Virginia. He gets a lot of discretion in terms of where to send bills, appointment powers, and all that sort of thing. So that's just a little bit of background. The governor of Virginia, Mr. Terry Mcauliffe, is the 72nd governor of Virginia, elected in 2015 to a single 4-year term. You may or may not know Virginia is the only state in the country that only elects its governor to one 4-year term. There are some states, well, there have been plenty of legislators who have tried to introduce constitutional amendments to make so that the governor could serve consecutive terms. Not surprisingly, they all want to be governor one day, and so they think that certainly they should be allowed to be governor for at least 8 years. It has a cabinet of 15 members that includes his senior staff and secretaries of all the various that oversee agencies of all the various policies. Of course, Secretary Bill Hazel, who oversees the Secretary of Health and Human Resources, and this is, I think, his it's his second administration, so he's been around for the last couple of governors. The governor proposed his first biennial budget on December 17th of this past year. As I mentioned, the General Assembly then takes up the budget. They're working on their changes to it right now. They'll put their suggestions out next week, and then essentially, for better or worse, about 6 members from the Senate, 6 members from the House will sit down in a room. We won't be there, but they'll sit down and hash out their differences, and near the end of session, they'll come back and offer a conference report for the full General Assembly to vote on. Interesting little change in the rules this year, as opposed to previous years. The General Assembly leadership has said that they will put out the full budget for everyone to view and have an opportunity to comment on, for at least, I want to say, 48 hours. So it's pretty quick, but in the past, from time to time, you would get up to the end of the General Assembly session and a conference report on the budget, how did we spend $100 billion, would hit the desk, and no one would really have time to read it, and you'd have to vote on it. So anyway, it's a small but hopefully meaningful change. We can't talk about the governor without talking about the First Lady, and she'll be here shortly, and we'll introduce her to you. But the First Lady has spent a lot of time working on issues of childhood hunger and access to nutritional foods. I've worked with her for the last couple of years on breakfast initiatives for getting students who access to be able to eat breakfast, because if a student comes to school and is hungry, not only do they have health considerations of not being able to eat good healthy meals, but it's hard to learn in a classroom when a child's sitting there hungry. So it's been a good opportunity to work with her on some of those things. They have an initiative this year I believe there's $10 million in the introduced budget that would basically be, it's sort of a healthy food financing program. Essentially, the goal is to, in food deserts, which I'm sure you all are familiar with, there's plenty of areas in the Commonwealth where maybe a whole county, you can't even get to a grocery store with fresh foods. And so it'll be, we've got all kinds of economic development incentive programs for businesses to come to Virginia to do X, Y, or Z. This is sort of an incentive to help those who would like to open a grocery store to offer fresh foods in an area that is currently underserved. And so it's hopefully will help folks get access to fresh foods and vegetables. So hopefully we'll hear a little bit more about that from her. I mentioned already to you that the budget is a little more than $100 billion. It's the first budget to exceed that amount, which naturally grows over time as population and inflation grows. And hopefully with a growing economy, you always will have a larger budget. A few things, Medicaid expansion. I'm sure the First Lady will talk a little bit about the work that her and the governor have done to promote providing healthcare access to those who don't have insurance. So the governor has included Medicaid expansion in his budget, or a form of it, I should say. The General Assembly has essentially said that they're not going to go forward on Medicaid expansion. It's not a new issue. They've hashed it out for the last few years, but that's kind of where we are at this point. I don't know if any of you all are college faculty, but the governor did include a smaller than I'm sure everyone would like to see a raise, 2% raise for faculty to take place in July 10th of 2017. There is provision that says as long as state revenues are sufficient, I think it's as long as it's not less than 1% below what the forecast was. Already talked to you a little bit about the budget process. And so at the end of the General Assembly session, March 12th, everyone goes home, and the governor gets 30 days, give or take, to act on the bills and the budget. So it's fairly unique, as opposed to, say, the president at the federal level. The governor has fairly broad authority in terms of how to act on bills. So the governor, like the president, could sign the bill. He could veto it like the president. But in Virginia, the governor can actually go through and line item, make amendments to legislation or to the budget. So he would amend language. It would still have to go back to the General Assembly for their approval, just a simple up or down majority vote in each chamber. But it's a pretty important legislative process, because the governor can send some pretty big issues back to the full House or Senate for them to vote up or down on. And then at the end of all of that, the governor has the ability to, in the state budget, line item veto. So if it's his belief that certain line item in the budget shouldn't be funded for whatever reason, he does have the ability to line item veto. A little bit about the legislative process. I think you all are probably fairly familiar with this, but a bill gets introduced by a delegate in the House or a senator over in the Senate. The bill gets referred to committee. And then most committees, because there is so much going on, so many bills for them to consider, they will refer legislation to smaller subcommittees. In the House, you may have read some about this recently. In the House of Delegates, the subcommittees, they will take a vote. Doesn't necessarily have to be a recorded vote. And in the subcommittee, whatever action they take is pretty well final action. In the Senate, and Janet and Kevin and I were down at a Senate Education and Health Committee's Health Professions Subcommittee recently. And for instance, they take up a piece of legislation and the subcommittee will act on it, but in the Senate, it's a nuance but an important one, the subcommittees are just making recommendations to the full committee. So you wind up getting a full hearing in both on controversial legislation. So approved by the committees, goes to the full chamber, has a crossover by today, and then go through basically the same process on the other side. The governor gets to take his action on legislation, and as I mentioned before, can sign, amend, or veto the bills. I mentioned that there is a lot for them to take up in a shorter period of time. As I mentioned, they had 34 days up to this point, and they had to act on, in the House of Delegates, 1,391 pieces of legislation, in the Senate, 781 bills. And if you include the resolutions, many of which are significant, the constitutional amendments and the other, that's over 2,800 individual items that they have had to consider just in the last 4.5 weeks. So it's a lot, and it moves quickly, and so it's important that we are over there and engaged and talking to our legislators and getting you all, as big issues come up, to be able to engage with your members as well. It's also, I would note, part of why it's important that we engage with elected officials and legislators not only just during the legislative session, but March to December, because once they get to the General Assembly, to the Capitol for the annual session, they are so busy, it is nearly impossible to comprehend new big issues. And so the more that we can do to educate throughout the year, the better off we're going to be. Most of those bills, as you can see, die a peaceful death. But they have passed nearly 1,000 pieces of legislation as of last night, and they'll be on the floor passing lots more good ideas today, I'm sure. You know, I'm going to breeze through this because I think you all have done legislative meetings that you're doing, but I was just going to talk a little bit about, you know, when you get to the legislative office, they all have secretaries there that will introduce you to their legislative assistants, who are basically the legislator's right-hand man or woman. And so a lot of times you'll wind up speaking with the legislative aide if the elected official isn't available. And that's great, and that's useful too. But regardless of who you're talking to, as I mentioned, there's so much going on. It's really important that you be brief and keep your small talk to a minimum and kind of get to the point as quickly as you can, because after 5 minutes, I'm surprised y'all are still paying attention to me. They definitely don't pay attention after 5 minutes. So, get a little further into some of the issues at the General Assembly this year, some of the more nitty-gritty work and things that are probably really important to a lot of you. And that starts with the Nurse Licensure Compact. And then there are also a number of bills related to scope of practice for advanced practice nursing, whether it's the midwives, the nurse anesthetists. By the way, I should say, are there any nurse anesthetists here today? Maybe? They're outside. I saw the table. I did, again, I don't know why, but I have served with the VCU advisory board for their School of Nurse Anesthetists for the last couple of years, so I am an expert. Or the clinical nurse specialists or nurse practitioners. But just to get into some of this, the Nurse Licensure Compact, I think you all are probably at least somewhat familiar. If you are a registered nurse and if you have a multi-state license under the compact, then you have to be somewhat familiar with it. But Senate Bill 265 basically updates the licensure compact in Virginia according to many of the standards that the national organization has set forth. Jay Douglas from the Board of Nursing is going to give you a more thorough briefing on some of that, and so I don't want to spend too much time on it, but essentially the end goal is for, theoretically, a lot more states are going to sign on to the compact because of some of the new provisions that are included in it. And so if you yourself hold a nursing license under that compact for multi-state privileges, then it will be more valuable to you because of this legislation. You'll be able to practice in more states at that point than you are today, and so that's what we hope. will happen at the end of the day. If you have a license now, you're grandfathered in, so you don't have to worry about any of the new provisions. But for what it's worth, the legislation passed the Senate unanimously, and we'll go over probably for a hearing in House committee as soon as next week. So. There was legislation, and there were a lot of various bills related to advanced practice nursing. So I'm just touching on some of them that have moved forward and give you an update of kind of where they are. Senate Bill 463 removed the requirement for nurse midwives, collaboration in a physician-led patient care team. The midwives sat down with the OB-GYNs and basically came up with a compromise whereby they don't have to, they're not subject to the same collaboration agreement, the patient care team arrangement that they are now. Instead, they are able to practice, see their patients, and instead of a collaboration agreement, they are subject to a consultation agreement. Big difference. But really, I think that basically just means that they have to consult with a physician so that whether it's routine or emergency, if there is an issue that they need to consult with a physician on, then they have that in place. And so that legislation is moving forward. Hopefully, will increase access to care, allow more midwives to see patients in more areas of the state. And I would just note that 70 counties do not currently have a certified nurse midwife, and 61 don't have an OB-GYN. Nurse anesthetists had legislation this year. Essentially, it set out the definition that you see on the screen for what an advanced practice registered nurse is. But ultimately, the purpose of the legislation was to remove the requirement for the CRNA to participate in the practice agreement. And Medical Society didn't really have a problem with that, ultimately because they have to work under the supervision of a physician as it is. So that legislation is moving forward as well. Clinical nurse specialist legislation, it essentially codifies some things that probably are, I think, and Jay can speak to this a little bit more, but that are already in place, but codifies some of the requirements for an applicant to be registered by the board as a CNS, and you can see those requirements of their educational requirements that they would have to meet in order for the board to certify a clinical nurse specialist. And I think it also clarifies and makes it so that a CNS is also in the Code of Virginia considered to be an advanced practice registered nurse, so that there are those 4 categories. And then nurse practitioner legislation, there were a number of bills. Governor Mcauliffe, the administration worked with the patrons and VC&P, I believe, on a number of different approaches, but ultimately the administration supported legislation that would allow a nurse practitioner to practice outside of a collaboration agreement with a physician in a couple of circumstances. First of all, they would have to have at least 2,000 hours of experience of post-licensure experience, and secondly, they would need to be practicing in like a free clinic type setting or some other underserved area of the Commonwealth. So that was the general approach, not to give nurse practitioners the ability to practice throughout the Commonwealth, but they said, maybe if we have some access to care issues here, let's just try to do this for now. That was the approach taken by the administration and those patrons, and that legislation was later amended. The Medical Society was very opposed to even that limited approach, and so the legislation was amended to basically say, if the problem that you have is that a physician leaves the patient care team, and so the nurse practitioners are no longer able to see their patients, you have an access to care problem, And so what they said was, well, let's let the nurse practitioner continue to see their patients and prescribe as they were before in the absence of the physician for 60 days while they look for a new physician to come in and fill that spot. And then if you still haven't found one, you have the option of an additional 60-day window to continue to try before you will no longer be able to see your patients. That's ultimately what the committee did. They took that language and basically transformed the bill so that that's what it does now. I'll update you on a couple of the other bills, and then I'm happy to answer some questions. These other, Senate Bill 269 and 620 would basically remove the 2,000-hour requirement. And Senate Bill 269 would say that the nurse practitioner could practice outside of the patient care team collaboration agreement, just in underserved areas. And then 620 would have removed the requirement statewide so that nurse practitioners could practice to the full extent of their education and training, as we know should be the case. Ultimately, the Medical Society brought language, and the committee adopted an alternative version of the bill, actually not even anything like the bill, but to say that instead of giving nurse practitioners the ability to practice with the patients that they were trained and educated to do, we're instead going to implement a pilot program to allow nurse practitioners to find a physician to come into their patient care team remotely. So if you're somewhere in Virginia and you can't find a physician to work with, to collaborate with, in order for you to see patients, then fine. You can just have a physician participate in your practice via telemedicine. So that's a pilot program. That's what the bill was changed to do. It has a fiscal impact, and so it's going to have to be funded in the budget, or it won't happen at all. But that's kind of where that is right now. House Bill 825 and Senate Bill 437 created a pilot program to allow military medical personnel to practice in a healthcare setting under the supervision of a physician. Essentially, this is a pilot program that would help veterans who are coming back into the workforce to be able to use the skills and expertise that they have based on their vast experience serving in the military, and use it under supervision to in a healthcare setting, so that they have a job while they are continuing their education, and maybe they're going to go to school to become an RN or or a physician or anything else, but so that it would give them an opportunity to work in the meantime. And then Senate Bill 212, which was a Board of Health Professions, the Department of Health Professions bill, but it adjusted membership on the boards, and so essentially this bill just adds a nurse practitioner to the Board of Nursing. Talk a little bit about some of the ongoing issues I mentioned before, making sure that faculty salaries are adequate so that we are able to recruit and retain the nursing faculty that we need to meet the growing demand for nurses in Virginia. And then secondly, addressing the issue of workplace safety, which I know is an issue that has been brought to the attention of the VNA before, and so we're going to spend some time working with stakeholders and policymakers to see what options might be available to do something about that. So that is a hopefully not too boring presentation, but I know Kevin Shimp is going to join me, and we're happy to take any questions that you have. Thanks for coming to Richmond today and hearing a little bit about what's going on at the General Assembly during this annual legislative session. Thank you. If anyone has any questions. Yeah. Good morning.
Thank you for that great talk. So I'm a nurse practitioner that was actually at some of the legislative days for Aprn legislative days. And one of the things I found very interesting was we didn't really have a unified voice from all the nursing associations. When we were lobbying for increasing scope of practice for nurse practitioners specifically, what the Medical Society did very well is provide a very unified approach that they didn't want the advancing of scope of practice. They did not want top of license practice. But what you see is VCNP approached the subject very differently than VNA, than the CRNAs did, than the Midwives Association did. So I guess my question is, has there been times where, or do we ever sit at the table with all of these large nursing associations and actually talk to one another in Virginia to have a unified voice to our own legislators? Because that's something that I did not personally see, and a lot of our colleagues didn't see, is all of us together at a table. Because someone else talked earlier about what a big voice nursing is. It's the most trusted profession. 1 in every 7 voters is a nurse. So with the approach of coming together as one versus every individual organization in the future may have been a very helpful approach. As someone who's a member of RAM and MSV, they did not see it that way at all. Like RAM and MSV completely capitalized on the fact that we were all in different arenas in that. That's just my question, is it ever a time when we can all come together and come up with a good unified solution to the problem?
I'm happy to speak to that briefly, and then Kevin may have something to add. My view on it is somewhat limited because I think I'm in like day 50 of working with the Nurses Association. But I think the point is very spot on. Anytime you're advocating down at the General Assembly, if it's not clear, well, first of all, legislators, and we were talking about this morning, legislators don't like picking between two groups at all anyway. They like getting reelected. They like making everyone happy. So first and foremost, they want to see, number one, that all the nursing groups are on the same page. Second of all, they want to see that there has been a serious effort for the parties that have disagreement to sit down and figure out what they can work out on their own. Because at the end of the day, this is maybe an issue that MSV and nurses aren't going to necessarily agree on. It's a big issue. But at least they want you to show that due diligence that you're doing that. And so Kevin and I and Janet and Lauren have all talked a lot about the need for the nursing groups and for VNA to really play a role in sort of bringing those groups together. In terms of specifically this legislation, I know that VCNP asked us to participate in a phone call, I think, the day before session to hear kind of what was going on. And, being a lobbyist in the General Assembly, I see their lobbyists regularly. And so we talk. But certainly, our groups need to do a lot more to work together for these issues to really move forward. So I would agree with you, and Kevin can add to that.
Thank you for your question. Your question is right on target. I think that some of that draw for organizations to come together to work collectively is going to need to come from us, the members. So I really encourage you to take that back to VCNP. VNA is looking to collaborate with other organizations to advance all of nursing.
Sure.
Hi, everybody. I'm Selm Berkowitz, and I'm a nurse anesthetist, and I'm answering that question as well. And I wanted you to know that there's the Virginia Coalition for Nurses that VNA has been a great part of. And over this past year, past 2 years actually, but this past year, we've made great strides in the 4 groups coming together. And the 4 APRN groups are the clinical nurse specialists, the clinical nurse midwife, certified nurse midwives, the nurse practitioners, and the nurse anesthetists, of which altogether we comprise almost 10,000 in the state. And just this past couple of weeks, February 2nd, we completed our first APRN legislative breakfast at the General Assembly. And so the four groups together have been working unanimously together as one voice to advance the practice of nursing to the full education of our scope of training and education for the citizens of the Commonwealth, and also falling in line with what the other 49 states have already done, which Virginia still needs to catch up on doing. And as these gentlemen have already pointed out to you, great strides have been made in that direction. They're small steps. You can't rectify changes in legislation to reflect current practice all in 1 year, but we're certainly moving in that direction. So whichever association or group you are with, I strongly urge you to get in touch with your leaders because there's a way, and we very much need your voice to come together so we can all work as one. Right now, on the Virginia Association of Nurse Anesthetists website, and that's vana.org, right at the bottom center of the page, and I know that Kristen Jameson from VNA is going to be sending this out to you as well. There is a registration there where every Tuesday in February until the end of the legislative session, which is March 12th, as you've already heard, on Tuesdays, whether it's your first time attending, you have an interest in sitting in at the General Assembly and hearing how bills get to move forward, how your voice actually carries through and what gets changed here in the legislature that affects your practice each and every day and how you care for your patients, there's a way to do that. You can sign up. You'll be getting more information on that, and there'll be someone with you if you're a first-time attendee that can mentor you, or if you've been there before and you don't need someone, then that's fine. But there is an available slot for you to do that on Tuesday mornings. All right, thank you.
Oh,
I'm sorry, I have a
just-
question. My name is
sure.
Melissa Legowski. I'm a new women's health nurse practitioner, and I'm in the DNP program at Old Dominion University. So my question is, well, first of all, I wanted to state that in order to have a really good argument in politics, you also have to understand the counter-arguments. So from my understanding, the Federal Trade Commission promotes the fair market competition. And I was just curious if you can speak on perhaps the counter-argument about unfair competition and how the medical community is arguing the fact that, you know, nurse practitioners, if nurse practitioners were able to practice outside of the care team, if you will, we would also be able to enhance the, you know, competition between medical and nursing. We would be able to offer new practices.
You want me to answer why they might argue that more competition between doctors and, well, among all providers might not be a good thing?
Well, I was just wondering what the medical community's counter-argument might be.
I don't really think that they, and Kevin, you were there, but I don't think that they really spoke to that a lot in terms of just competing between, they basically just sort of made the argument that physicians have been doing this work, that they can continue doing this work, and that nurse practitioners ought to work as part of a patient care team under a physician. And, you know, they were asked, are there outcome differences? We have plenty of research to show that there are not, if you look at other states. And that was just sort of kind of where they left it. I think a lot of the members of the committees were kind of comfortable with not moving forward on anything this year. So those are some of the things that hopefully in the next year we can spend some time working on.
Thank you.
Thank you.
I want to clarify one point. There's a lot of research that shows nurse practitioner outcomes are positive. There wasn't any clarification on research that counters that, so that nurse practitioner outcomes are less than a physician. There wasn't that research, so that wasn't presented.
Great. Well, thanks again for having me come down today. And I wanted to take a, oh, I'm sorry. Go ahead.
Hi, I had a question. My name's Heidi Simpson. I'm a nurse practitioner. I have over 25 years of family practice experience, and I practiced in multiple practice environments, including federal and other states. I'm baffled by how Virginia cannot pass any legislation to let me, someone with 25 years of practice experience, practice at the same level as a new graduate physician. It's mind-boggling. Actually, when I first moved to Virginia, because my husband was military, we had a better practice agreement than the one we have now. We've gone backwards, in my opinion. And if we have these compactual agreements, what's the incentive for nurses to stay in Virginia and practice? Because they can go to D.C. or Maryland or Delaware or West Virginia or Pennsylvania, make more money, have more autonomy in practice, and have a better quality of life, not dealing with the legislative mumbo-jumbo here. And then the other question I have is, I was a service member. When I came out of the service, I didn't have any provisions to allow me to get a different job. It's not that I'm anti-military, but I'm confused as to why we're giving a special classification to military members to get jobs, because then it could be leading to legislation which would, again, undermine nursing, such as how paramedics are taking over nursing responsibilities in Colorado. Can you address those points, please?
Sure. First of all, I would like to have you join us for down at the General Assembly next year, because you make a lot of very good, eloquent points, and some of those, well, I think a lot of those points were raised. I think that we need to spend a lot more time sitting down with the members of the House and the Senate to make sure that they understand those issues. You're right, nurse practitioners could go right across to Maryland or D.C. and not have to, work under the supervision, and not have to work as a part of the collaboration agreement patient care team that they do here in Virginia. They could just go see their patients and do their work that they're trained to do. So I look forward to working with you down at the Capitol next year on those issues. Specifically to the legislation, I think we had it here. I think there are a lot of policymakers who feel that we have a lot of veterans who are, doing very good work, going and serving in the military, and then are coming home, and we have a lot of, the governor and first lady have spent a lot of good work on issues related to veteran homelessness, but also veteran unemployment, I think, is higher than, certainly higher than it needs to be, but it may also be higher than other portions of the population. And so there are a lot of policymakers who basically see that military medical personnel who have a lot of training in helping people in the healthcare setting could set up a pilot program to see that if, when they come home and re-enter the workforce, rather than not having a job, they could take those skills that they learned and gained in the military and apply them on a temporary basis while they're able to further their education. And so I think that was sort of the reasoning there, and hopefully people are able to benefit from that care. So anyway, I wanted to, thanks again. I wanted to go ahead and introduce our next speaker. Janet, did you want to introduce her, or am I?
I was actually just hoping no one else had.
Okay. The First Lady has joined us, and I know she's got a busy schedule, so I wanted to quickly introduce her to you. As First Lady, Ms. Mcauliffe has dedicated her efforts to eliminating childhood hunger and improving access to Virginia's fresh, locally grown agricultural products for all our citizens. We talked a little bit about that in our previous conversation.